Good morning, everybody, to this second semester 2023 invited lecture of the Institute Josep Carreras. For me, it's a great honor to introduce Dr. Pierre Fenaux. He works in the Department of Hematology and Immunology Hospital Saint Louis of Paris and University of Paris. Thank you, Pierre, for accepting to do this interesting, I am sure, very interesting talk about how to treat patients with MDS of high risk. And now I will try to summarize in few words the long curriculum of Pierre, because it's really long. And Pierre is professor of hematology and head of the hematology immunology department at Hospital Saint Louis, Robert Debré and Vincennes. He is also part of the INSERT research unit, Hospital Saint Louis, Paris, for his laboratory research activity. He is involved in clinical and laboratory research in the field of MDS and AML, mainly ML of elderly and acute promyelocytic leukemia. He is a founding member and chairman of the French-speaking MDS Group, Group Francophone of Dysplasies, or GFM, and of the French APL, Acute Promyelocytic Leukemia Group. He is also, since 2017, coordinator of the EuroBloodNet, the European Reference Network for Rare Disease in Hematology. I want to keep in mind to all of you that you can send your questions through the question mark button on the right side of your screen. Pierre, it's your moment. Gracias por aceptar esta invitación.
Ok, buenos días a todos y muchas gracias por invitarme. Y como me lo habéis pedido, voy a presentar en inglés. Okay, so as you know, MDS is a group of diseases often progressing to acute myeloid leukemia. It's a disease of the elderly with a median age of about 70 years, which is important for treatment. And progress is rather slow in treatment. First, allogeneic transplant remains the only curative treatment, potentially curative treatment. And for the moment, the other treatments have a limited impact on survival. So my talk will be in four parts. First, what is low and high risk MDS? Well, it used to be traditionally based on the IPSS, which separated based on marrowblasts, karyotype, and cytopenias patients into low, intermediate 1, intermediate 2, and high risk. And generally said, high-risk patients were those who were intermediate or high risk. And in those patients, really, it was important to avoid progression to AML and improve survival. Now, of course, this has changed to some extent. First, the revised IPSS with the same parameters, but changing the cutoff values. And this has reclassified about 25% of the patients into more severe or less severe, and with a difference. And so, generally speaking, patients of high risk are those with revised IPSS greater than 3.5, and the other ones are lower risk. But this has further changed with the advent of mutations. As you know, most MDS patients have at least one mutation, especially of the spliceosome, methylation, etc., and which you know. And this has led an international group to devise a revision of the IPSS in molecular IPSS based on 16 genes. And this has, to some extent, changed the classification and allowing now 6 groups based on progression to AML and survival. And this classification allows to reclassify almost 50% of the patients into more severe or less severe. Now, the problem is, well, this is nice, IPSS, but it does not take into account the comorbidities, which are so frequent in MDS. And this IPSS has been established in elderly patients, and in those patients who are not treated intensively. And it's, of course, difficult to apply them in younger patients. For example, a median survival of 6 years is not favorable in a patient younger than 70 and even more 60. And what we had published some years ago is that the loss of years was more important in younger patients as compared to older patients, whatever the type of MDS. So those classifications are not sufficient. Also, the effects, the positive effects of treatment have been mainly demonstrated using the classical IPSS or the revised IPSS. So transplant and azacitidine improve survival in IPSS or revised IPSS group, but it has not been demonstrated with the molecular IPSS. And also, an unfavorable prognosis can remain unfavorable irrespective of the treatment. And this is the case. This is a work done by De La Porta showing that even if you transplant patient using the molecular IPSS, well, the prognostic value remains. So it may be in practice difficult to apply. Now, what is also important is the response criteria. We recently published at the GFM a clinical trial using CPX351 in high-risk MDS. And if you use the IWG MDS criteria, the CR rate was only 23%. Now, if you use the ELN criteria for AML, it became 52%. And that was because of the threshold in particular of hemoglobin to define complete remission. Following this, by the way, a revised IWG response criteria has been published in Blood in order to try to reflect more real life. Now, this being said, so transplant remains the only curative treatment. So so I think it's been clearly shown that patients who were intermediate to a high risk using the classical IPSS benefit from transplant. And this has been shown in non-randomized or randomized studies. Whereas on the contrary, those with intermediate 1 or low did generally not benefit. It was not so clear using retrospective studies. And so far, there have been no real prospective studies. At least we conducted one at the GFM. It's currently completed, no obvious difference. But of course, it's always difficult. Now, the one issue with transplant is the early mortality. And this is a series of lower risk patients transplanted by EBMT and showing that the early mortality, as you know, is about 20%. And of course, some of those studies, well, all those who read papers on transplant know that often in recent publications, you have patients published 15 years ago. So, of course, prognosis has improved. But still, there's an early mortality, especially for a disease where transplanted patients are generally older than 60. And for example, but even with recent trials, so those are our two most recent trials of the GFM, and so patients transplanted recently with a median age of, as you can see, about 62, and the mortality rate is 17 and 19%. So even very recently, because of our elderly patients, there are still some mortality. And this has to be taken into account, of course, especially if you want to transplant patients who are relatively low risk. Now, the other point is, on the contrary, that patients who are adequately selected above the age of 70 can be transplanted. And I think we go up now to 75. And in exceptional cases, you know, to 60, 76, 77, where patients are really extremely fit. But still, there is, of course, a risk. Okay, the second point is, of course, the type of donor. Well, what is, I think, important now, of course, is the advent of haplo-identical transplantation, and its prognosis is almost similar to that of sibling transplant or unrelated donors who are 10 out of 10, although there is a slight, perhaps slightly poorer prognosis, but the difference is lesser and lesser every year. So it's now, I would say almost everyone has a donor. It's especially important for MDS, where brothers and sisters may be elderly too and maybe not candidates for to be donors. Now, should we perform treatment before transplant or after? So there are no randomized prospective studies. It's very difficult to carry out. So generally speaking, I would tend to say that patients who have less than 10% marrowblast can be transplanted immediately, whereas in those with more than 10% blast, most colleagues would try to reduce the blast count before transplant, either with intensive chemotherapy or with hypomethylating agent-based treatment. And particularly, the latter would be for patients with unfavorable karyotype who do not respond to chemotherapy. Now, there are the new forms of chemotherapy like CPX-351, which, as you know, was found to be better than classical 3+7 in secondary in AML secondary to MDS, and we Pierre Fenaux showed that trial, which I previously showed the results in. It's a small subset of 31 patients, 52% CR, and most patients actually achieve blast clearance, and 29 of the 30 eligible patients could be bridged to transplant. So it's interesting. As you know, side effects of CPX are often less important than classical chemotherapy, especially mucositis, although myelosuppression may be a few days longer. The second, of course, option is hypomethylating agent. But as you know, hypomethylating agents yield low rates of CR and PR, and most responses are what is called hematological improvement, that is an improvement in cytopenia without reduction of blasts. And this the transplanters don't like. They want to transplant patients with fewer than 5% blasts generally. So this is the study that led to azacitidine approval. As you can see, disappointing CR and PR rates. And this was confirmed by a German study actually showing, as you see, in azacitidine before transplant, well, only 10% CR, 17% PR. So this is not a good way to reduce the blast count. What is probably more promising is the combination of azacitidine and venetoclax, which we are not sure this combination can prolong survival without transplant. But now 80% of the patients achieve a blast clearance with aza plus venetoclax in this phase 2 trial. So it's quite promising. And I must say now it's become our standard to a large extent before transplant in patients who have more than 10% blast initially, especially in those with an unfavorable karyotype. Now, the issue, of course, is that even with transplant, you don't cure all the patients. On the left, the lower curve is patients with a very poor karyotype according to revised IPSS, and on the right, patients with TP53 mutation. But the poor prognosis in patients with TP53 mutation mainly concerns patients with biallelic mutation of high VAF. That is generally patients who have lost one TP3 allele with the other one mutated, complex monosomal karyotype. The other patients fare better. Now, what can be done is, of course, treatment after transplant, in particular in that case, azacitidine followed by donor lymphocyte infusions, and with a certain number of responses, although most of them are not durable. And we currently have a trial we completed, a trial of preventive Aztec 727, which is an oral form of hypomethylating agent, followed by donor lymphocyte infusion in patients with high risk of relapse post-transplant. We don't have the results as yet, and we also have a trial for patients relapsing post-transplant, which is ongoing. Now, the conditioning regimen is always discussed. Most patients are elderly and will have an attenuated regimen. It's always the discussion between conventional and reduced intensity conditioning. Generally, you have more relapses with the reduced intensity conditioning, but you have less treatment-related mortality and eventually a similar survival. But of course, in the elderly anyway, most patients will have reduced intensity conditioning. Okay, now hypomethylating agents, because not all patients can be transplanted. So when? Well, of course, what we know is that azacitidine can improve survival over conventional treatments like low-dose chemotherapy, supportive care. But as you can see, it's a modest improvement. Even in the phase 3 trial, we had a 2-year a median survival of about 2 years, which is, of course, not very good. And in particular, in real-life studies, for example, the Spanish group found even a lower survival of about 16 months, median survival, and although better in patients with chromosome 17 abnormality. And as you can see, also generally, the median survival was about 18 months with azacitidine. So it's pretty disappointing. And more importantly, in the long term, if you take it 5 years, you have 4% survivors with azacitidine or decitabine. So as single agent, it's quite disappointing. Although there are some prolonged responses, but only few. Okay. The second point is that patients often take a long time to respond, and often as many as 3 and sometimes 6 cycles. So they are cytopenic during many months. They remain cytopenic during many months, and this can lead, of course, to infection, to many transfusions. So it's another issue. And as said before, most responses are not complete. So the idea is, of course, to have combinations. So the first combinations to be studied with azacitidine plus lenalidomide plus vorinostat, which is an HDAC inhibitor, and there was no survival advantage. This was a US study. So Lionel Hades for the GFM tried to reproduce that. It was the same type of a trial with the valproic acid, another HDAC inhibitor. We added a treatment arm with 1 day of idarubicin and also lenalidomide, and once again, no difference in response, no difference in survival. So this was quite disappointing. So we need new drugs. First, of course, the oral agents. I'm not sure they're going to be better than the conventional agents, but at least more convenient. And of course, we can use various types of drugs, targeted or not, and I'll show a few of them. First, oral drugs. Aztec 727 is an oral form of decitabine, which is, of course, obviously more convenient to use and which has the same pharmacokinetics as decitabine and the same efficacy. And now that company is also developing an oral form of azacitidine. The second is oral azacitidine, mainly so far tested in relatively low-risk MDS with 42% erythroid response. So the effect on survival is not clear, but could be the same as sub-Q azacitidine. And we are just starting at the GFM a trial combining oral azacitidine, which is CC486 or Onureg, which, as you know, is approved for the maintenance treatment of acute myeloid leukemia, combined with venetoclax. So this is just starting in the next few weeks. Now, another drug, for example, pevonidostat looked, and there are many phase 2 promising trials which were not confirmed in phase 3. That's the issue. For example, this randomized phase 2 was very promising for the addition of pevonidostat to azacitidine, and a subsequent phase 3 trial was totally negative. So the drug has been abandoned, pevonidostat. Now, glasdegib, when added to low-dose RSC in AML, improved outcome, but a low-dose RSC is not very good, and so, but glasdegib is also being tested with azacitidine, so it could be it's a SMO3 inhibitor. We'll see if it can improve outcome. Now, perhaps the most promising currently is the addition of venetoclax, a BCL2 inhibitor. I've shown already the response rates, which are about 80% blast clearance, which were only considered at 35% CR, but using the new criteria, now it's close to 70%. This is using the old criteria. And interestingly, the median survival appears to be longer. As you can see, it could be about 27 months or so in this phase 1/2 study. And also the hope that aza-ven will be better than AZA is because in AML, aza-ven is better than AZA. So it's there's an ongoing phase 3 trial, and of course we're waiting for the results. It's especially important because the other phase 3 trials currently have been to some extent, well, they've been disappointing. Well, this is the results with AZA plus ven. As you can see, patients who achieve CR do pretty well, although we need more follow-up. Now, specific drugs, IDH1 and IDH2 inhibitors are very interesting. So we conducted with Lionel Hades and Marie Seber at the GFM parallel trials with the IDH1 and IDH2 inhibitors. There are 3 cohorts: high-risk MDS resistant to HMAs. Cohort B was patients who were treated first line with the inhibitor, and cohort C, lower risk MDS with anemia resistant to EPO. That was few patients. What is, well, the studies are not completed. What is impressive is the response rate in patients treated frontline. And it's 46% CR overall, but it's more than that. It's about 70% in patients treated frontline. And results are impressive. And some patients have been taken to transplant. Some have prolonged survival. So it's really impressive, even in patients with low VAF of IDH1 mutation. The same for IDH2. And this is the cohort B, as you can see, with median survival not reached, somewhat poorer in cohort A, but cohort A is patients who are resistant to HMAs. A hope, of course, also is that the combination with azacitidine. This is the results in AML in a study led by Pau Montesino, showing a clear advantage of the addition of the IDH1 inhibitor to azacitidine, and hopefully this will also be reproduced in high-risk MDS. And the same for the IDH2 inhibitor. You can see that the difference is not so significant between AZA and AZA plus and enazidenib, but actually most patients receive in the AZA arm enazidenib after azacitidine failure. And indeed, the median survival is 22 months, which you don't expect with azacitidine alone. So it's always important to interpret trials and perhaps pay more importance to event-free survival as compared to survival. So hopefully this will be important. The problem is, as you know now, IDH2 inhibitors are currently not available in Europe. Now the checkpoint inhibitors. First, PD1, PD-L1, CTLA-4 checkpoint inhibitors, which have shown disappointing results in myeloid malignancies, especially in MDS. Now, CD47 inhibition with magrolimab led to promising results, including in patients with TP3 mutation. We just heard that the phase 3 result comparing AZA and AZA plus magrolimab are negative, and so currently there's no obvious future here, so we'll see. But apparently no breakthrough. Now sabatolimab is a TIM3 inhibitor, which also has given, in combination with a hypomethylating agent, promising results. We're waiting for the results of the phase 3 study, but the randomized phase 2 study showed no obvious difference between AZA and AZA plus sabatolimab, which are here. So now, in the case of TP53 mutation, as I said, magrolimab was apparently promising, but no difference. Now, there was this reconforming drug, eprenopatopt, APR-246, which once again in a phase 2 study showed promising results in patients with TP53 mutation, who, as you know, have a poor prognosis. But in fact, to make a long story short, this was not confirmed in a phase 3 trial randomizing AZA and APR-246. So that for the moment, so that we are everything negative except potentially AZA plus venetoclax, and in patients who have the IDH1 or IDH2 mutation, the combination with the inhibitor, AZA plus the inhibitor. By the way, it's important to know that IDH1 and IDH2 mutation can occur during evolution, especially after azacitidine failure. So it's important to check the appearance of the mutation during follow-up, because this may occur. Like sometimes we know FLAT3 ITD, which also has an inhibitor. So it's important to check that regularly. Now, another point is whether growth factors should be added to hypomethylating agents to reduce the toxicity, etc. G-CSF is used by some teams. It's unclear if it improves the outcome. The TPO agonists have also been used, like romiplostin. So if you randomize aza plus romiplostin, you indeed reduce the duration and intensity of thrombocytopenia. On the other hand, we contributed to that trial which compared azacitidine and azacitidine plus eltrombopag, and the paradoxical effect was that there was less transfusion independence, less response, and to some extent more progression to AML. So this addition of TPO agonist has not shown its efficacy, and for the moment cannot be recommended. Okay. Now I will finish perhaps with a last group, which is not quite high risk MDS, but it's a specific group which is emerging. It is patients with autoimmune or autoinflammatory manifestations. Those may not be high risk MDS, but are patients with high clinical expression, I would say. And we know that about 15 to 20% of MDS and CMML are associated with those systemic inflammatory and autoimmune diseases. That in that case, the autoimmune or autoinflammatory disease is often typical. We have Sweet syndrome, relapsing polychondritis, periarteritis nodosa, etc. Their outcome is, well, having an additional autoinflammatory disease does not worsen the outcome of those MDS. But it's important to analyze that, because of course there's specific treatment. What we and others found was that was an association between some somatic mutations and the combination with those autoimmune diseases, especially IDH1 or 2, TET2, and to a lesser extent SRSF2. So our hypothesis, well, first, those diseases are often concomitant. So our hypothesis is that it is not the autoinflammatory or autoimmune disease that it leads to MDS or vice versa, but it could be the same mutations that lead to both types of disorders. Like we know TET2 mutation also can induce some autoimmune diseases, also some cardiovascular diseases. So this is disputed, but it may be important from a therapeutic viewpoint. And in particular, we had found that was an exceptional observation of a patient referred to us for who had been considered for lung transplantation. You can see the left CT scan, and when they analyzed the situation, they found that the patient had CMML and with TET2 mutation, and we hypothesize the association may be linked. And so after one cycle of azacitidine, this is CT scan B, you can see a dramatic improvement, a normalization of the CT scan, suggesting that it's indeed the mutation that leads to both. So and indeed we carried out, we had a retrospective study of azacitidine in patients with MDS and CMML associated with autoimmune disorders, and 86 of the patients responded, and that could allow discontinuation or at least reduction of steroids in most patients, and therefore less infection. So that was retrospective, and we carried out the same type of study, but prospectively, with 66% response on the autoimmune and autoinflammatory disease, and 59% hematological responses, and that was concomitant in most patients. And so, but what was recently discovered is the VEXAS syndrome with UBA1 mutation, and we know those patients often have MDS, which, by the way, is generally not high risk. And for example, ruxolitinib works pretty well in those patients. But what we found by analyzing retrospectively in our prospective trial of azacitidine was that half of the patients had actually UBA1 mutation, so the VEXAS syndrome, and 75% of them responded to VEXAS and also for their MDS, they had a hematological responses, suggesting also that it is the UBA1 mutation that leads both to the inflammatory symptoms and to a MDS or MDS-like picture, which is along the line of TET2 and IDH mutation we found. So, okay, so that was a specific group. So to conclude, for high-risk MDS, once again, what are high-risk MDS? I don't know, but so far, I think we have to rely on the IPSS, IPSSR. It's difficult to take a therapeutic decision just based on mutations. Of course, you will say, well, in some cases, you can. I mean, biallelic TP53 mutation is poor prognosis and patients should be transplanted. But biallelic mutation is always associated with complex monosomal karyotype. So you have karyotype, and this is the IPSS. On the contrary, SF3B1 mutation, when it is isolated, are associated, for example, with TET2, that is without concomitant unfavorable mutation, has a favorable prognosis, and those patients should not be transplanted, but they generally have low risk and remain low risk. So, but it could be interesting, but IPSS could also predict that. Although it's interesting in the present case, you can tell your patient, well, you're just SF3B1, we'll monitor you. If there are no other mutations, you will not worsen, you will not progress to AML. Of course, you may have to be transfused, but we don't want to take the risk of transplant. But so I would say that, generally speaking, so you rely on IPSS, IPSSR mainly for your therapeutic decision. You should think of transplant, and until what age? Of course, as I said, we regularly go up to 75, so it's really comorbidities. And of course, patients' desire as well. Should we proceed by treatment? I would say we still stick to treatment before, when patients have more than 10% blast. In case of normal karyotype, we tend to use chemotherapy. In case of unfavorable karyotype, now we do AZA-VEN. We don't know AZA. I mean, we know that AZA-VEN improves the response rate even in patients with biallelic TP53 mutations. Those responses are short, but they may allow you to bridge the patient to transplant instead of waiting for a response for 6 months, and then the patient gets infections and is no more candidate for transplant. Because I forgot to say, in the German study, many patients could not proceed to transplant because of complications during the azacitidine treatment. So that's the idea. And if of course you cannot transplant the patient, we still have hypomethylating agents, perhaps oral forms. They're not approved yet, but it could be the future. But probably using more drugs, and I would tend to say that currently venetoclax is probably one of the best candidates. Including because now, as you know, new classifications consider that patients with 10-20% blasts are kind of borderline between AML and MDS. And I know in USA, they tend to treat many patients with more than 10% blasts with adding venetoclax, generally for 2 weeks, and not 4 weeks like in AML. The first studies with venetoclax showed some toxicity in MDS, but the patients were not monitored as well as with AML. As you probably, many of you have the experience of treating AML with AZA plus VEN. It is true the first cycle is more myelosuppressive than azacitidine alone, but responses occur more rapidly, and therefore patients are transfused for a shorter period and have less complications. So my guess is that this will be largely reproduced in high-risk MDS. Of course, as I said, you have to monitor regularly for the emergence of targetable mutations, and we currently have IDH1 and FLT3. have no IDH2 inhibitor, but hopefully there will be some in the next future. So it's important, and we do it every 6 months, because there can be really emergence of those mutations, and hopefully in the future we will have more mutations. For example, as you know, Carreras mutations are rare in MDS CMML, but they are now approved in solid tumors, so they could be used potentially in those rare patients with Carreras mutations, which may also emerge during progression. So I will conclude here acknowledging the department I'm part of in Hôpital Saint-Louis Robert Debré for children and Hôpital Avicenne, and also the French MDS Group, which is mainly a group that activates academic trials. We have also a registry, and we certainly work with our partners in Europe, from Germany, Italy, and also the Grupo Español de los SMD, with several trials in common through the umbrella of EMSCO. And as you know now, those trials have to be submitted centrally, those academic trials. It's a big task that started earlier this year, but it's a great challenge, and it's important to maintain those academic trials, which are complementary to those our colleagues in the industry carry out to get their drugs approved. But we have quite a few examples of common trials with very interesting results. And so I'd like to thank you for listening to me, and I'm ready for questions in English or in Spanish.
Thank you very much, Pierre, for the very interesting talk and this very interesting review about the possible treatments of MDS patients with high risk. I want to remind people that you can send your questions through the question mark button that is on the right side of your screen. Until now, I have received several questions, and I will start with the first of these. Next door, you mentioned that azacitidine treatment is frequently associated with hematological response improvement in MDS patients. Is this response related to complete or partial response or stable disease in a significant manner?
What happens is that indeed, what was found in the initial trials was that often you had hematological response without complete or partial remission, suggesting that you kind of went back in the disease course. And for example, if you have MDS or post essential thrombocythemia, you treat the patients with azacitidine, and thrombocytosis develops again, so showing that you kind of go back to the disease course. But many of those patients who respond just on their cytopenias, if you continue, achieve eventually partial or even complete response. But this takes time. But often one of the first signs of response to azacitidine is the increase in platelets, for example.
Thank you. I have a comment from Dr. José María Rivera, that you know him very well. And first question, any difference in bone marrow versus PBC for allo-humanized stem cell transplantation in MDS?
I don't think there's a difference with AML, etc. So I think this is pretty discussed, and I know now that depending now on the type of donor you orient, so that there's a confusion here of parameters. So, and I'm not directly a transplanter, so it's difficult for me to respond to this. But yeah, but I guess for most, of course, for non-sibling, I think we use mainly blood, and the same but for haplo, and it's more bone marrow. So yeah.
And the second question of José María Rivera is a question that I wanted also to ask. Is there any preclinical development of CAR-T in high-risk MDS patients as being done in AML?
Well, I think very few, but once again, once it's really advanced in AML, I guess you go to MDS, but of course the problem is often the age, the patient age. Yeah. But no clinical trials to my knowledge.
Okay. I have no more questions, but I will just to curiosity, at this moment, it's important to have the status of the genes to perform NGS in most patients. In your country, in France, this is done in all patients with MDS, paid by the National Health, or more in collaboration, in clinical trial, or...
I think many centers do it, but of course we need, well, even in this center, which is a big one, we need at least 1 month to get the response. So what we rapidly have is IDH1, IDH2, FLT3, and also for AML and PM1. But the other ones take some time and generally have limited effect on therapeutic decisions. As I said before, TP53 biallelic mutation is largely predicted by the presence of monosomal karyotype with del5q, especially if there is del17p. So I'm not sure there's any, this can lead to urgent therapeutic decisions. Now, of course, when you have a patient who have moderate disease, but with 7 mutations or so you're going to monitor that patient who will progress, and you will think more rapidly of transplant. But otherwise, I'm not sure there's currently a big impact, and not all centers do NGS. So of course, there's a lot. But a lot being written, a lot of abstracts sent to, including this year's ASH, but for therapeutic decision, except for the targetable mutations, and perhaps after 3B1 alone to see it's really benign, but this is not rapid decisions. I mean, it's medium-term decisions. So, yeah.
Another question now from Jose Maria Rivera. How frequently do you repeat molecular studies in high-risk MDS during follow-up? Only in the clinical change, or only if clinical change of the disease? Or
yeah, we as I said, we regularly perform IDH1, IDH2, FLT3 mutations, and I think the other ones can be important for a therapeutic decision, especially if it's mainly for transplant. I mean, perhaps some patients who have moderate unfavorable factors, if there are the advent of mutations, increasing mutations, and of course there's also the del5q, which Kiko particularly well. In those patients, if there is an increasing TP53 mutated clone, this is important for therapeutic decision. But I would not take into account small clones, which, as you know, are frequent because they can even disappear. So, but when they increase, it's generally associated with progression. But so I would, but I think you can still treat largely MDS without having a regular NGS panel. It's of course also useful for diagnosis, because in difficult cases, when you have no mutations and when karyotype is normal, it's probably not MDS. But no, of course, we are happy to have it in all our patients, but well, okay.
Well, I think in Spain we are in a similar situation. Now at this moment we try to organize 4 or 5 reference labs in Spain to perform NGS of most patients, but it still is covered by the help of pharma or projects. I have one question. In cases that have to receive a bone marrow transplantation from a donor, you analyze the donor, if this donor patient or this donor individual have germinal genes related with predisposition.
Absolutely. Well, actually the most frequent predisposition genes are in the somatic panel, because they can also have somatic mutations. Of course, the most frequent is DDX41 and GATA2 and RUNX1, etc. So they are in the panel, and when we see a mutation which is close to 50%, of course, especially if there's a history of MDS or AML or in the family, we obviously take this into account, and if the donor is a family donor, we certainly check in the donor, but it's because it's part of the somatic panel. But obviously DDX41 is probably close to 10% now, so it's really important to take into account for transplant.
And what about therapy-related myeloid neoplasm? It's a high-risk MDS, but not always. How you follow or treat this patient?
I didn't understand the question, sorry.
About therapy-related myeloid neoplasm.
Oh, yeah.
But could be a high-risk MDS, but not always, or?
Well, I would tend to say that it's like in AML. I mean, what is important is the genetics rather than the fact that they are therapy related or not, which is always, you know, I saw last week a patient who has MDS with ring ceroblast following a cancer treated with chemotherapy. It's probably not related. So it's so we largely base on genetics but of course those patients may have received several treatments, though they may be more frail for a treatment like transplant, but that's the idea mainly.
And a question that now is very common is, now we have two classifications, ICC versus the whole classification. You are trying to diagnose using both, or you use just one, or?
Well, we tend to use the WHO classification, but that changes all the time, and you know, it's. I think we focus too much on that, and it's. Well, those, you know, it's not so. But the risk, of course, is that eventually the risk is not to apply a treatment that may, for example, we know very well that, for example, chemotherapy does not work as well in patients who have less than 10% blasts as compared to those who have more than, less than 20% blasts as those compared to those who have more than 20% blasts. And they generally have different karyotype mutations, etc. But if you now apply the ICC saying 10%, you're going to treat all the patients the same way, and you may lead. You may have therefore poor response rates, and also this is going to change the results of clinical trials, because if you include everyone, you know, I remember when I started to work on acute promyelocytic leukemia, some colleagues said, why do you exclude acute promyelocytic leukemia from your, you know, from your trials? Because after all, they have better results with chemo. So, you know, it's nice to have them, but of course they're very different. But on the other hand, so pulling patients together based, although they're not, you know, they're not the same, it's not practical. I would even say, if you take AML, for example, when you speak of CBF leukemias, well, actually, T821 patients and inversion 16 patients do not behave the same with chemotherapy. And for example, high-dose RST is absolutely required in T821, now not so much in inversion 16. So it's nice to put patients together, but it must have a clinical significance. Otherwise, you know, NPM1 mutation is interesting when you treat patients with chemo, or perhaps Aza-Ven, but otherwise, you know, separate. So I think we kind of overemphasize those classifications, and we should be more practical. And the risk is, especially in countries like, you know, where there are health insurances, private health insurances, they will tell you, well, there's a drug approved for MDS, but you have 11% blast. No, now in the ICC, it's more AML. Oh, we don't reimburse the drug, or vice versa. We know it's also one of the reasons why myeloproliferative disease were now labeled myeloproliferative neoplasms, and now we have said that MDS should be now myelodysplastic neoplasms. We know that this is because in USA there's no reimbursement if there's no cancer. So, but this is not science, and so that's why I think we emphasize too much those classifications, and they are made on specific purposes, which in the present case are not scientific.
I agree with your comments, and very interesting. Now I want to thank Josep Maria Rivera, because he's asking several questions. One question is, has been studied the risk of additional molecular abnormalities induced by the therapy of MDS?
I'm not aware of that. No.
I don't think so. No.
No.
Well, I think that longitudinal studies of patients with MDS is really very, very interesting. in our hands, we have a project, we are analyzing patients with low-risk MDS during a lot of years, and the patients clinically is stable, morphologically is stable, but genomically, a lot of additional genes appear, but what to do with these patients, still we don't know. So perhaps genetics demonstrate additional genes that are important genes, but the patient is stable. So what we have to do is with these patients, still we are not sure. I don't know. I have no more questions. I don't know, Peter, Pierre, if you want to do some last comment.
No, it's what really is. I think is important is this cooperation on clinical trials, and we're very happy to work with the GSMD in particular. Yeah.
Gracias, Pierre. Merci. Pierre speaks very well Spanish. He wanted to do the talk in Spanish because he likes to speak in our language, but we suggested that the talks in our institution, scientific talks, should be in English. But thank you, muchas gracias y gracias a todos por su atención.
Muchas gracias. Hasta luego.
Gracias.